Top Med Talk.
Welcome to Top Med Talk. We are here in Atlanta at the inaugural meeting for EBPOM USA 2018, Evidence-Based Perioperative Medicine. I am Desiree Chappell, your co-host of the Roundtable on Top Med Talk. I'm joined here with Monty Mythen, co-host of Top Med Talk as well, and we're also joined today by Dr. Lee Fleisher. He's the chair of anesthesiology for University of Pennsylvania. And Vicki Morton, she is a DNP and the director of clinical and quality outcomes at Providence Anesthesia in Charlotte, North Carolina. Thank you both for joining us this afternoon.
Pleasure.
Thank you for having me. So I have a question. We recently went through a situation where the insurance provider, because with our bariatric program we were doing so well and saving so much money, they reduced our reimbursements by $400,000. That was not an outcome I was ever expecting to happen. And I'd like to know what your thoughts are on that.
So that is an outcome I expect to happen because we have to bend the cost curve. So you almost have to go in with the question because the other thing they can do is just switch it to an outpatient procedure.
And we are.
And you are. Mm-hmm. And then every time you renegotiate, you can negotiate a new fee. And we have this with the hospital, and I do a lot of our negotiations for our system. So you really have to make them understand in the negotiations that if they get too aggressive at dropping the payment, there's going to be no incentive for innovation. So that's the key, is making them understand that we want to bend the cost curve. If we can get it down, that's great. But if you get too draconian in how you pay, there will be no more innovation.
Right.
And that's a recurring discussion in our system. You have to maintain that the salaries, the quality of staff, you have to have an irreducible minimum. You have to keep something in the system that funds innovation, or it all gets completely stifled. It becomes commoditized, and that's a downward spiral, I think.
What other industry only spends 1% to 2% or less on innovation? Apple doesn't. The drug companies don't. And, we think a lot about radiology. I mean, I actually think they're a group that as we get better, we're going to need less radiologists and we're going to need less post-acute care. Do we give them a soft landing? Do we actually say to our radiologists, we're going to pay you to work less, and in 5 years we want, as people retire, just don't replace them?
Because I'm guessing that the computers can do the radiology interpretation pretty damn well if we let them get on with it, with a bit of AI support.
It's not about that. It's actually, do you need as many X-rays? I mean,
that's...
yeah.
On the Preop clinics and the post-op.
No, it's true. Yeah. I mean, you're just assessing patients more aggressively and not just doing a blanket order for every single patient. I mean, you need to assess whether or not they truly need it.
We don't have a Preop clinic.
Oh.
Our our surgeons probably over-order tests.
Yeah.
So before we move on from Maryland, one thing you didn't say is whether, if there's a league table of results, are they mid-table, bottom of the table, top of the table? If they've got this system and it sounds sensible economically, are the outcomes better or worse?
They started out not quite as good.
Okay.
And they're getting into, I think, the average range, but they're still studying it.
Okay.
Okay. Interesting.
Is it a good model for the rest of the country, you think?
I actually think the waiver of the doctors are not yet aligned with the health systems. I think, is it a good model for the UK?
It's like all of these things. We seem to be spending relatively little money compared to the USA on healthcare, and our outcomes appear to be a lot better overall. And part of that may be the distribution of our social services spend compared to the health spend. Part of that may be because people in the food chain are paid a lot less money. Who knows? But even if you look at the very crude metrics of live births per 100,000 or whether overall length of life is going up or down, big picture is we seem to be doing all right.
But you probably use less resources.
Yeah.
And the question is, how quickly can we get people to realize that, not doing something is okay.
Right.
We're not there yet.
So on that, you touched on the bundles, which is the concept of the bundle payment is one of the ways that's thought to get a bit of a control on that. In other words, you're going to get this chunk of change for doing a particular type of procedure, work within that bundle of money,
right,
and see if you can get a margin out of that. How's that all going?
That is the only thing that's been shown to save money.
Okay.
You have to have outliers. Several years ago, we had the most expensive hip replacement in the U.S. because we had a hemophiliac. And it was $1 million worth of product. So you have to... Now, fortunately, my visiting professor that week was Patrick Conway, who was the CMO of CMS, and we had a good talk. But the bundles really do provide an excellent opportunity to have savings. The interesting question is they start with the assumption you need surgery. So let's talk about back pain, and I've actually been talking to CMS. Wouldn't it be interesting for the anesthesia department to, with PM&R and others, to start with a symptom rather than we're definitely undergoing surgery?
I thought you did. Can't you get a bundled payment for back pain as opposed to a bundled payment for back surgery?
No, it's starting right now with surgery. People are proposing. And the problem is that they haven't figured out how to pay for it.
Aren't some people doing that with joints now, too?
They're starting, but it's more population health rather than joint pain. So starting, if you rehab them and you get them to stay away from the surgeon for a couple of years, is that advantageous?
So just so I'm clear, at the moment the bundle tends to be for having a joint replacement.
Correct.
And the opposite argument would be that there's a bundled payment to make the pain right for the patient and to make their quality of life better, which may or may not involve the joint replacement. Have I
Correct.
My head? Okay.
And it would be great to get to that second place, and then anesthesiologists should get a larger piece, or PM&R, whoever are the right group, behavioral health. I mean,
whoever can fix the problem.
Yeah.
And you talked about it, though, in part of the change that's happening is that there are opt-in bundles. Now, from listening across the pond with all the changes in healthcare and people pushing back against the bundled concept, you get the impression that everyone will be running away from bundles, whereas the opt-in would imply the fact that there's, for some people, it's a win-win.
Correct. So the interesting thing is that the opt-in, as part of the opt-in, you get your own data.
Okay.
Because the problem in the U.S. is if it's a Medicare patient and they're not coming back to our own hospital, or they're going to a post-acute rehab facility that we don't pay for, we don't know our total cost, our total spend. So a lot of people are asking, they say, we're going to pilot or ask to get the data. If the data looks good, then they may opt in and actually do the bundle.
Got you. I think I'm getting a handle on that now. So Medicare, Medicaid is the government, the tax spend on healthcare. So at the moment, you do the joint replacement outside of a bundle, then you may send somebody to these things called post-acute care facilities that are rehab, but residential rehab. So you're still in sort of hospital, but you don't call it a hospital.
Right.
And Medicare are paying for that, but you don't get to see the spend, so you don't know what happens. Okay, I've got that.
Or they go back to a hospital that's not your hospital.
Right. So if you were to accept the bundle, you'd take responsibility for getting them home, and if you're good at that, you can keep the margin.
Correct. But staying home.
Staying home. So stay home. And when does the window of responsibility stop?
So my in many of them, they're 30 days, but I've just been asked to sit on a panel that's a 90-day bundle for cardiac surgery. So my suspicion is we are going to 90 days.
Top Bed Talk.